Why genetic testing of pancreatic cancer is necessary. Hello, this evidence-based content is prepared by Saboor Khan, fellowship-trained consultant surgeon, and if you or someone you care about has been diagnosed with pancreatic cancer, you're probably wondering whether there's more to treatment than standard chemotherapy. I know hearing terms like genomic testing and targeted therapies can feel overwhelming, but today we're going to break down what might be the most important conversation you have with your oncologist: how molecular profiling can identify specific treatments tailored to your tumor's unique genetic makeup. By the end, you'll understand what comprehensive genomic testing actually is, which specific mutations can be treated with targeted drugs, and exactly what questions to ask your doctor to ensure you're getting personalized care. This isn't just about understanding the science, it's about making sure you or your loved one gets access to every possible treatment option. Before we dive into specific mutations and treatments, let's establish what we're talking about. Molecular profiling, also called comprehensive genomic testing or next-generation sequencing, is essentially reading your tumor's genetic code to find specific mutations that can guide treatment. Think of it as creating a detailed blueprint of what's driving your specific cancer, rather than treating all pancreatic cancers the same way. Here's why this matters to you personally. Research shows that up to 20% of patients with pancreatic cancer have germline pathogenic variants in known cancer predisposition genes, and when you include tumor-specific mutations, actionable alterations can be found in a significant subset of patients. This testing should be done as quickly as possible after diagnosis because of the significant treatment implications. Now, you might be wondering what testing you actually need. Current guidelines recommend two types of testing for every patient with metastatic pancreatic cancer: germline testing, which looks at inherited mutations in your DNA, and somatic testing, which examines mutations specifically within your tumor tissue. Let's start with germline testing. This uses a blood sample to assess for inherited genetic conditions that increase pancreatic cancer risk. The most important genes tested are BRCA1, BRCA2, and PALB2, known as the core homologous repair deficiency genes. These are present in approximately 3 to 5% of patients with pancreatic cancer. Now, what does this look like in real terms? If you carry a BRCA1, BRCA2, or PALB2 mutation, your tumor has defective DNA damage repair mechanisms. This might sound scary, but here's where it gets interesting. This defect actually makes your tumor exquisitely sensitive to specific DNA-damaging drugs like platinum-based chemotherapy and PARP inhibitors. We're not talking about marginally better responses here. Patients with these mutations can have dramatically improved outcomes when treated with the right regimens. But testing doesn't stop there. You should also be tested for other genes, including ATM-CDKN2A, linked to familial melanoma syndrome, Lynch syndrome genes like MLH1 and MSH2 and STK11, associated with Peutz-Jeghers syndrome. Each of these can influence your treatment strategy and also has implications for screening your family members. If you're supporting someone through this, understand that germline testing results affect the entire family. Any patient diagnosed with pancreatic cancer and a high-risk hereditary syndrome should receive genetic counseling and advice on screening for other associated cancers. Somatic testing examines tumor tissue itself, typically using next-generation sequencing on a biopsy sample from either the primary pancreatic tumor or a metastatic site. The accuracy is quite good. Sensitivity generally ranges between 62 to 95% and specificity between 92 and 100%. For patients with insufficient tissue available for testing, actionable alterations can be identified using circulating tumor DNA from a blood sample. While not quite as comprehensive as tissue testing, this liquid biopsy approach has become increasingly accurate and provides an option when tissue isn't accessible. Somatic testing looks for several critical alterations. First, somatic BRCA1/2 or PALB2 mutations present in approximately 5% of patients, which are treated similarly to germline mutations. Second, mutations in other homologous repair deficiency genes like ATM-BARD1, BRIP1, CHEK2, and RAD51, which occur in 13 to 44% of patients, and may also benefit from platinum-based therapy, particularly when both copies of the gene are affected. Third, and this is crucial, testing identifies rare but highly actionable mutations, including NTRK gene fusions, less than 1%, RET fusions, less than 1%, BRAF-VI 600E mutations, KRAS G12C mutations, 1 to 2%, and mismatch repair deficiency or high microsatellite instability. Each of these has specific FDA-approved targeted therapies. KRAS G12C mutations. The KRAS gene is one of the most frequently mutated genes in pancreatic cancer, and the G12C substitution comprises 1 to 2% of all RAS mutations. For patients with this mutation who progress on initial chemotherapy-specific KRAS G12C inhibitors, adagrasib and sotorasib, are available. In clinical trials, adagrasib showed a 33% objective response rate, with median progression-free survival of 5 months and overall survival of 8 months among pancreatic cancer patients. Sotorasib demonstrated a 21% response rate with median progression-free survival of 4 months and overall survival of 7 months. These are oral medications that specifically target this mutation. NTRK gene fusions. These occur at low frequency in pancreatic cancer, less than 1%. But for that rare patient with an NTRK fusion, the TRK inhibitors larotrectinib, entrectinib, and repotrectinib are highly effective. In phase 1/2 trials, larotrectinib and entrectinib demonstrated objective response rates of 50 and 75% respectively in metastatic pancreatic cancer patients with durable responses lasting median of 4 and 13 months. These agents are FDA approved and can be administered orally for patient convenience. RET fusions. Also rare at less than 1%, but among patients with metastatic pancreatic cancer in the LIBRETTO-001 trial, the selective RET kinase inhibitor selpercatinib demonstrated objective response rates over 50% that were durable. Median duration of response wasn't even reached at 15 months of follow-up. This has FDA accelerated approval for RET fusion-positive tumors. Mismatch repair deficiency. Pancreatic cancers with deficient mismatch repair, or high microsatellite instability, occurring in approximately 1 to 2% of cases, respond dramatically to immune checkpoint inhibitors like pembrolizumab. In the KEYNOTE-158 trial, the objective response rate was 18%, with remarkably durable responses. Median duration of response was not reached, and 68% of responses were ongoing after more than 2 years of follow-up. If you're worried about someone you love, here's what matters most. These targeted therapies often have better tolerability profiles than traditional chemotherapy, and when matched to the right mutation can provide responses where standard chemotherapy might not work. Request comprehensive testing immediately. If you or your loved one has been diagnosed with pancreatic cancer at any stage, ask your oncologist. Have we ordered both germline and somatic genomic testing? This should happen as quickly as possible after diagnosis. The testing typically takes 2 to 3 weeks to return, but treatment doesn't wait. Your doctor will start initial therapy while results are pending. Understand that treatment can be switched. Because pancreatic cancer is aggressive, doctors don't wait for genetic test results to initiate systemic therapy. However, patients whose genetic testing results reveal an actionable molecular alteration can switch to the appropriate targeted therapy if necessary. This is completely standard practice. Ask about tissue availability. Confirm that adequate tumor tissue has been collected and stored for molecular testing. If not enough tissue is available from your biopsy, ask about circulating tumor DNA testing as an alternative. Come prepared with these specific questions. What specific genes will be tested in both my germline and tumor testing? When will results be available? And how will they influence my treatment plan? If an actionable mutation is found, what targeted therapies are available? And what are the expected response rates? Should my family members undergo genetic testing based on my results? For BRCA1/2 or PALB2 mutations specifically ask, will I receive modified FOLFIRINOX or gemcitabine plus cisplatin? And when would PARP inhibitor maintenance with olaparib or rucaparib be started? Data shows these combinations can provide substantial benefits in this population. Seek enrollment in clinical trials. If standard targeted therapies aren't available for your specific mutation, clinical trial enrollment should be strongly considered. Trials are evaluating newer agents for various mutations, and your oncologist can help identify appropriate options. Request testing at specialized centers. If your initial testing doesn't include comprehensive panels covering BRCA1/2, PALB2, NTRK, RET, BRAF, KRAS, and mismatch repair genes, consider seeking a second opinion at a comprehensive cancer center that routinely performs next-generation sequencing. Consider retesting at progression. If your cancer progresses on targeted therapy, repeat molecular profiling may identify resistance mutations that could guide subsequent treatment choices. This is particularly relevant for TRK fusion-positive cancers treated with TRK inhibitors. Expect comprehensive genomic testing results within 2 to 3 weeks of sample submission. If an actionable mutation is identified, your treatment plan may be adjusted within days of receiving results. For targeted therapies like TRK inhibitors or KRAS 1,2C inhibitors, response assessment typically occurs after 6 to 8 weeks of treatment with imaging studies. Response durations vary significantly by mutation type and specific agent used. Let me quickly recap. Molecular profiling identifies specific genetic mutations in your tumor that can be matched to targeted therapies with potentially better outcomes than standard chemotherapy alone. Your next step: ask your oncologist today whether comprehensive germline and somatic testing has been ordered. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.